Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thank you so much for the invitation. Okay, so the usual disclaimers. My brief learning objectives is to go through a bit of epi about COVID among people with HIV, talk about vaccination and vaccination updates, and understand COVID treatment and prevention for people with HIV. COVID is a huge topic, so what I'm going to try to do is focus on places where things are different or similar for people with HIV, and if there's any questions at the end, happy to talk through those, but I'm not going to talk about sort of like general treatment for that reason. Okay, a brief zoom through the epi. So a question that I think we all have wanted to know, and there's been varying responses to this question, is are people with HIV at higher risk of getting infected with SARS-CoV-2? And I think the answer is yes, among most studies. And a little bit of what's difficult to tie into that is that we all know that many of our patients have multiple, marginalized identities and might be at more risk of being exposed, but also potentially because there is a difference with CD4 count in some studies, maybe a higher risk immunologically as well. So the following question is, are people who have HIV more likely to have severe or fatal COVID-19 disease? This is a recent update presented at the IAS meeting just a few months ago from the WHO. They previously didn't have antiretroviral therapy and viral load suppression in CD4 data, but it shows that there's about a 50% increase in in-hospital mortality during COVID hospitalizations among people with HIV. And then you can see on this nice forest plot at the bottom, which I think has a greater than or less than error in one of their bars, but essentially people who are unsuppressed and with lower CD4 count seem to do worse. And that gap has narrowed a little bit over time. Overall, the mortality has gone down over time, but less so in people with HIV. So some additional work that I was part of, along with many collaborators at the University of Washington and several other CFARs, was to look at a multi-center cohort of people with HIV in the United States. And I apologize that we weren't allowed to reveal which site was which for IRB reasons, but you can see from in this right-hand chart that graph A, there's a pretty wide variety in COVID incidents at different sites across the United States. Actually, Seattle and Boston are some of the lowest ones, and the higher ones are in the Midwest and the South. We also see racial and ethnic disparities in who becomes infected with COVID-19, not surprisingly. We saw much fewer differences based on either nadir or current CD4 count. These findings were also replicated among a group called N3C, which also did a big database dive across the United States. And then in Kaiser, they found similarly that people with HIV were more likely to have COVID and be hospitalized, although the Kaiser population is different than I would say the general US population, that they tend to be more highly engaged in care with a higher viral load suppression, good population health management among Kaiser patients. So why might people with HIV be more likely to have high risk outcomes with COVID, and maybe that there's a difference between risk of getting COVID and a risk of mortality? So this is just kind of a schema that we published that looks at what we can actually measure, what we know about people. And so what I really want to emphasize here is that we think about HIV status, we think about CD4 count, we think about being on ART, but a lot of our patients have different patterns of isolating themselves, being able to, and then all these unmeasured factors and experiences that people have, such as, are they able to take time off work? May have protected people by leading them to take more protective actions because they kind of had been through this before, or risk perception, for example. I talked through this a little bit. In the sake of time, I'll just move through again, realizing that comorbidities and social determinants of health may be a lot of the drivers of what we're seeing, and not just immunologic status in terms of why our people get COVID and do poorly. Among the Phoenix cohort, this is our data for who is high risk of having severe COVID and being hospitalized or dying. The two things that I really wanted to point out that I think are really relevant for primary care physicians and have not been shown in the general population, but there's no reason why they shouldn't hold true for people without HIV as well, is that we were able to show that for every 10% increase in ASCVD risk score, there's a 37% increase in risk of being hospitalized for COVID, and the same, actually stronger association in people who had a higher FIB4 score. And so these are all calculators that we have access to. We often use them with our patients to think about other risk forms. And so I just wanted to put these out there that we now have some data that, if we're having conversations with our patients about what their risk is for COVID outside of their immunologic status, these are, potential tools that we all have handy to us. To just dive down into CD4 count and viral load, there's different thresholds that have been considered to be risky. Within the CNX cohort, we felt that was at 350, others it's below 200, but would say that certainly below 500 and sort of increasingly below 350, that those are people who even suppressed and on ART are at higher risk of being hospitalized. This data is from 2020, so it doesn't include people who are vaccinated. So of course that modifies all of those risks as well. Just an important note that we think that there's a small snippet of data that tells us that people with HIV are more likely to have long COVID. And the mechanistic rationale for that is that people who had COVID, who didn't have great immune responses to it at first and were less likely to clear it, were more likely to go on to get past, and people who had more sort of immune exhaustion, which we know that many of our patients with HIV have. So there's a mechanistic reason to think that people with HIV are more likely to get long COVID. Okay, so now to the kind of practical component, preventing and treating COVID in our patient population. We all want to know whether or not the mRNA vaccines are as effective among people who have HIV. The key to this graph is essentially NIs non-infected, people who are vaccinated HIV negative versus vaccinated HIV positive, and then people who had a COVID infection with or without HIV. So we see that there's a slight decrease in neutralization by and IgG quantities among people who have HIV compared to those who don't, but overall more robust responses in people who are vaccinated than just people who had infection. And then this is pretty brand new data that comes out of the CIVITS cohort, which is across the United States and including a lot of CNIC sites plus the VA sites and other places. And essentially it shows that there's a higher cumulative incidence of SARS-CoV-2 vaccine breakthrough infections among people with HIV versus without. And then we look at that bottom graph, and the bottom graph shows a nice stratification by CD4 count, including among people whose CD4 count is below 500. So I think what we're seeing is probably true, that people are more likely to have breakthrough infections because of HIV, and that includes at pretty high CD4 counts. So what does that mean for current recommendations? I pulled this table from HIVMA that I was lucky enough to help work on through the course of the pandemic. And essentially, we know that people whose CD4 count is less than 200 or who are unsuppressed or untreated should be treated as the immunocompromised group that gets 3-dose primary series and get an extra booster. I think for right now, we know that all booster doses are no longer the kind of initial vaccine. And it's this new Omicron bivalent vaccine that was approved at the beginning of September and is now, I'd say, tentatively available because it's not quite available everywhere where there's long lines for it. But as of September 2022, everybody over the age of 12 should be receiving the Omicron bivalent booster, regardless of how many vaccines they got before, whether they're immunocompromised or not. And it's considered to be, I've heard a lot of people talking about, well, I'm not unwell or I'm low risk, and so I don't need to get it. And the real reason that we're pushing this and that I got it myself this past week was because this vaccine matches the current strains much better. And we now know, that the vaccines not only prevent severity, but they also seem to prevent infections when they're a good match. And we have, beginnings of data to show that this vaccine also will prevent infection and likely prevent transmission. So whatever somebody's initial regimen was, they should get that, and then the booster 2 months after their last Omicron infection or their last booster. So in summary, for vaccines for people with HIV, vaccine efficacy against SARS-CoV-2 infection was originally pretty good, not as good as for people without HIV, but it decreases with lower T cell counts. Vaccination is recommended for all people with HIV. There's no safety concerns with any of these vaccines for people with HIV. And we know that people may have a higher rate of vaccine breakthrough and with CD4 counts as high as 500. For people who have really severely suppressed immune systems, the FDA is recommending that people get tixagevimab, silgavimab, which we also know more commonly as Evusheld. There's sort of a little bit of a debate going on about whether or not how efficacious this is in the setting of BA 4.6 and BA 5, which sort of knock down the Evusheld's lab neutralization ability or ability to neutralize the virus in a lab, but it still seems to be protecting people. And there's more to it than just neutralizing virus in the lab. So as of this point in time, the FDA would say, and I would still agree, that people who have really advanced or untreated HIV, CD4 count less than 200, especially if somebody's not yet on ART, to consider giving a dose of Evusheld immediately, then vaccinate them later, work on getting them on ART, and consider a second dose of Evusheld after 6 months if someone is still at sort of that high risk immunologic status. Okay, and then who should we treat for people with HIV? So I think one of the most important things that I see in people's kind of risk decisions is that, as we've shown in all the prior slides about epi, it's not just about somebody's HIV status. So remembering somebody's age, their comorbidities, their vaccine status, in terms of offering treatment and which treatment. There are no differential recommendations for which treatment modality to give for people with HIV versus without. So we can follow the NIH and IDSA guidelines for this. And we put out a nice kind of guidance sheet on the use of nirmatrelvir, ritonavir, Paxlovid in the setting of either HIV or Hep C protease inhibitors, which is essentially just go forth and treat without any interruption. The main drugs, of course, we have to think about are statins and tacrolimus and other things like that, for which I really use the Liverpool HIV and COVID. Now they have a COVID drug interaction checker, but really the important thing is treat people with HIV just the same, and just in terms of modality and who we should be considering for treatment with their HIV immunologic and virologic status is just one of those kind of points towards treating. I think the debate of this is mostly over now, but in terms of evidence of benefit of different ART, although I did see somebody on social media talking about TDF for PrEP reducing COVID severity, none of these studies have really borne out so far. And so the recommendation is not to switch either preventatively ART or during somebody's COVID infection, any of their ART. So continue with the ART that you would otherwise give them. And then there are no official guidelines for what to do with ART while someone is hospitalized for COVID. We generally recommend continuing their ART without change unless they're on high dose steroids and a booster, and we need to kind of think about drug-drug interactions. But the recommendation that I would give is that if somebody's hospitalized and not on ART, would be to wait till they're sort of clinically stabilized and make sure that the ART is initiated before they head out the door and for discharge. So coming to the end of my talk, I'm just putting up 4 scenarios about questions of who might be considered for treatment with mild to moderate COVID. So this would be somebody who might get Paxlovid or maybe a monoclonal antibody like bebtelovimab right now. So which of these people would we consider treating? I don't have this as a formal poll because the correct answer is all of them. So this is just my reminder that person number 1, there's HIV is in good control, but they have stage 3 CKD and heart failure, and they're above 65. Person number 2 is unvaccinated and has a fairly low CD4 count. So that person should get treated because they're at high risk based on their immunologic status, including being unvaccinated. Person 3 is ART naive and has a low CD4 count. That person should be, kind of highly considered for their level of immunosuppression. And person 4 is otherwise completely not high risk, but is pregnant, which is also a consideration for being high risk. This is a white paper that HIVMA put out, and I'm one of the authors on this paper, just talking about some of the things that we were able to put into place through the CARES Act, especially during the course of the pandemic. Many of these have sort of been pulled back, but some of the things that we can keep thinking about doing for our patients. So, we've all been delivering a lot of care with telemedicine, switching ART to 90-day fills, as long as insurance is still taking that. Some of the flexibilities around Ryan White enrollment, less kind of wet ink signatures and things like that. So some of these have lapsed, some of them still go on. I thought this was kind of great. We're still pushing on Congress to kind of keep some of these flexibilities in place, especially around like cross state line pharmacy and telemedicine. And then this is just from IAS. This is just showing that there was a bump in perinatal transmission of HIV associated with care interruption during the pandemic. The biggest take home for me is that they have a really high rate of perinatal transmission, much higher than I think we do here in Washington State. But in any case, it's, we're seeing interruptions in care. And that was really it for me. There's also some really interesting modeling work that's looking at the rate of probable increase in HIV infections and lack of diagnosis and associated with care restrictions and access to care and lack of STI treatment and diagnosis, for example, during the pandemic. That's it.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.